spinal dysraphism or spina bifida. First, we have the spina bifida occulta, which is a congenital absence of a spine support cyst and a variable amount of lamina without visible exposure of meninges or neural tissue. The incidence is about 20 to 30% of North Americans' population, and it's often an incidental finding, usually of no clinical importance when it occurs alone. It may be associated with the diastematomyelin, or what is called the split cord malformation, or tether cord syndrome, lipoma of the spinal cord, or dermoid tumors of the cord. The defect only may be palpable, and there may be cutaneous manifestations. The other type is the spina bifida aperta or the spina bifida cystica. We have two types here. First, we have the meningocele, which is a congenital defect in the vertebral arches with thick distension of the meninges but no abnormality of the neural tissue. So from the naming, meningocele, it has two divisions, meninges and cele. So it's a sac of the meninges which only contains CSF. The other type is the myelomeningocele, which is a congenital defect in vertebral arches with cystic distension of the meninges and structural or functional abnormality of spinal cord or coda equina. So from the naming, you can see it's three divisions: myelo, meningocele. So myelo means neural tissue, meningo, the meninges, cele, a sac. So it's a sac of the meninges which contains neural tissue. The incidence of myelomeningocele is 0.1 to 0.2% with each birth, and when there's a previous case affected in the family, the incidence raises to 3%, and the incidence also increases to 6 to 8% after two affected children. 65 to 85% of myelomeningocele is associated with hydrocephalus. The most probable etiology is folic acid deficiency, and the prenatal diagnosis is usually the elevated maternal serum alpha-fetoprotein between 15 to 20 weeks of gestation plus ultrasound. The management depends on the size of the defect, ruptured or unruptured, neurological assessment, and assessment of other systems, because usually the myelomeningocele or the spina bifida cystica is associated with other anomalies in other systems in the body, like cardiovascular or the respiratory or gastrointestinal tract. So these are some pictures of the meningocele, and you can see the commonest site is usually the lumbar, followed by the dorsolumbar area, and finally the cervical. And sometimes the defect happens in the occipital region. It's called encephalocele in this case. This is a case of cervical and occipital encephalocele. As you can see, this is pre-op and this is post-op. Now, hydrocephalus or hydrocephalus, it's dilatation of the ventricles due to excessive production, obstruction in the pathway, or defective absorption of CSF. First, let's have a quick review of the physiology and circulation of the cerebrospinal fluid. As you know, the cerebrospinal fluid is produced by the choroid plexus and ependymal lining of the lateral ventricles, and to a lesser extent by the fourth and third ventricles. So, the CSF produced in the lateral ventricles passes through the foramen of Monro to the third ventricle, and from third ventricle to the fourth ventricle via the cerebral aqueduct, and it exits from the fourth ventricle through two lateral apertures, which are the foramen of Luschke and a central median aperture, the foramen of Magendie. So when it exits from the third ventricle, it goes to the subarachnoid space, it passes to the subarachnoid space, and it's reabsorbed to the circulation again through the arachnoid granulation or arachnoid villi. So we have two types of hydrocephalus. We have either the obstructive or non-communicating. It it means the block is proximal to the arachnoid granulation, so the CSF is not reaching to the subarachnoid state and is not reabsorbed. For example, we have cerebellar tumors, congenital aqueduct stenosis. These are examples of obstructive or non-communicating hydrocephalus, and the other type is the non-obstructive or the communicating hydrocephalus. The block is at the level of the arachnoid granulations, so the CSF is reaching the subarachnoid spots, but it's not reabsorbed again to the circulation. The example for that is the meningitis. So, what are the signs and symptoms? Actually, in young children, it's different from the adults. Why? In young children, usually the fontanelles are still open, not like the adults. So, the presentation will be different. First, we have cranial enlargement at a rate greater than facial growth. We have irritability, poor head control, nausea and vomiting, which are signs of raised intracranial pressure. Enlargement and engorgement of scalp veins. The fontanelle are full and bulging. Of course, you should examine the fontanelle while the child is in sitting position and it's not crying, it's calm. The Massillon's sign, which is a cracked pot sound on percussing over the dilated ventricles. We have the sixth cranial nerve, palsy, and we have the setting sun sign, which is the upward gaze palsy, also called the paranoid syndrome from pressure or region of the suprapineal recess. And we have hyperactive reflexes as a presentation of upper motor neuron lesion, and we have irregular respiration with apneic spells, which is a part of Cushing's triad. And you know the Cushing's triad is when you have a raised intracranial pressure, you have bradycardia, hypertension, and irregular respiration. And finally, we have splaying or opening of the cranial sutures. Here's a picture. We can see the large head in proportion to the face. The face is very small while the head is so large, and you can see the visible dilated and engorged veins of the scalp. Actually have put the IV line, the cannula, in one of the scalp veins, and you can see noticeably the eye sign, which is the sun setting sign or the paranoid syndrome. In all the children and adults, the symptoms are of increased intracranial pressure, which will be discussed later. Now, what about the investigations? We start with the skull x-rays, which can show the splaying of the sutures. You can sutures are open, and you can see actually on plain x-rays that there's what's called the copper beaten appearance or fingerprint appearance, which are the sulci and the gyri of the brain are pushed against the inner table of the skull. They put some thumbprints on the skull x-ray. And we have the ultrasound. Of course, the ultrasound are only done in children and infants where the fontanelle are still open. You cannot do the ultrasound of the skull or the brain in adults because you don't have a soft tissue. You don't have a fontanelle to use the probe of the ultrasound. We have the CT scan. The CT scan, of course, shows dilated over ventricles and also shows you the probable pathology like a tumor of the cerebellum. And finally, we have MRI. Of course, MRI is only necessary to demonstrate more or have more information about the lesion, like the cerebellar tumor. And the treatment is always, unfortunately, surgical, but we can use diuretics temporarily to decrease the CSF production. While preparing the patient for the surgery, we have the diuretics like the acetazolamide or the Diamox. The dose is 25 mg per kg per day. And we have the furosemide or Lasix. The dose is 1 mg per kg per day. And we have the aspiration through the anterior fontanelle in infants, which can be both therapeutic and diagnostic. Therapeutic to decrease the intracranial pressure, and diagnostic to analyze the CSF. And finally, the definitive procedure is the diversion or procedure or the shunting procedure. We have four types. We have the ventriculoperitoneal shunt, we have the ventriculopleural shunt, and we have the ventriculoatrial, and finally the limboperitoneal shunt. And the last trend in the management of hydrocephalus, we have the endoscopy, which is called the ETV or the endoscopic third ventriculostomy. you can do an aperture in the floor or third ventricle through the endoscope, transferring the hydrocephalus from non-communicating to the communicating type. Thank you very much.